All right, let's get right into it. After teaching for a couple of decades, I can tell you one thing for sure. You are not going to diagnose heart failure by looking at a single test. No way. Instead, we're going to be detectives. We are going to assemble the entire clinical puzzle, piece by fascinating piece.
Okay, before we go any further, we have to cover something very important. Please remember, this content is designed as an educational tool, really just to help with exam prep like the TUS or USMLE. It is absolutely not medical advice. For any real-world clinical practice, you must consult a qualified physician and always follow official medical guidelines. So let's set the scene. A patient walks into your clinic. They sit down. What's that initial spark? You know, that first little flicker in your brain that makes you pause and think, could this actually be heart failure? Where do you even begin?
Well, the investigation always, and I mean always, starts with the patient. This is our first and most important clue, the patient's own story. And our job is to decode what they're telling us, because not all symptoms are created equal. We have to figure out which clues are just sensitive, meaning common, and which ones are truly specific. Let's break that down with two key symptoms. On one side, you've got the most sensitive finding, exertional dyspnea. That's just shortness of breath when you're doing something. You'll hear this a lot for a lot of different reasons. But on the other side, the clue that is super specific, the one that should make alarm bells go off in your head, is paroxysmal nocturnal dyspnea, or PND. That's when the patient tells you they wake up in the middle of the night gasping for air, feeling like they're drowning. When you hear that story, your suspicion for heart failure needs to go way, way up.
So, we've listened to their story. Now it's time to listen to their body. This brings us to clue number 2, the secrets our stethoscope can unlock during the physical exam.
During the exam, we're basically listening for whispers and looking for shouts. You know, hearing some basal crackles in the lungs, that's a whisper. It hints that there might be some fluid. But hearing an S3 Gallop, oh, that is a shout. That's the sound of a struggling ventricle, and it's yelling for your attention. And of course, we can't ignore the right side of the heart. Things like jugular venous distension and the hepatojugular reflux, these are major pieces of physical evidence.
And let's just pause on that S3 Gallop for a second, because this is a golden rule. Of all the things you can find on a physical exam, the S3 Gallop has the absolute highest predictive value. It is a powerful signpost pointing straight to heart failure.
So what about this hepatojugular reflux we just mentioned? What is that? Well, it's actually pretty simple to check. You just apply some gentle pressure over the liver and you watch the neck veins. If they bulge or distend, that's a positive sign. It's like having a direct window into high pressure on the right side of the heart. It's another huge piece of our puzzle.
Okay, so we've gathered all these clues, right? We have the patient's story, we have our physical exam findings. Now we need to organize them to make sense of them in a systematic way. And that brings us to clue number 3, the rule book. We're talking about applying the famous Framingham Criteria. And the beauty of the Framingham rule is just how simple and effective it is. It's really just a 3-step process. First, you identify your major criteria. Second, you identify your minor criteria. And then you apply the rule. You can confirm a diagnosis with 2 major criteria or 1 major plus 2 minor criteria. It's really that straightforward.
So the whole game is just knowing which findings are which. As you can see, the major criteria are the heavy hitters we've been talking about. PND, that S3 Gallop, and signs of high venous pressure like the hepatojugular reflux. The minor criteria are your supporting cast, things like ankle edema, a nagging night cough, or a fast heart rate. You just find out what the patient has and plug it right into the formula.
The case is building, it's getting stronger. We've used our ears with the patient's story. We've used our hands in the physical exam. We've used the rule book. Now it's time for our eyes. It's time for the visual confirmation, what the chest x-ray reveals. Now, when you get that chest film, the very first thing you should check is the cardiothoracic ratio. The rule here is super simple and elegant. If the heart's width is more than half, or 0.5, of the chest's total width, that's cardiomegaly. The heart is enlarged. Plain and simple.
Next, you scan for the signature of congestion in the lungs. And believe me, nothing spells out fluid backup on an X-ray more clearly than the famous Kerley A and B lines. When you see them, you're looking at visual proof of congestion.
But wait, there's more. For a clinician's trained eye, some of the radiological signs are, well, what I like to call a visual feast. They are these unmistakable signs that are just so critical to recognize.
Here are a couple of my favorites. First, you have the deer horn sign. This happens when high pressure in the lungs actually reroutes blood flow up to the upper zones, making it look like antlers. And then there's the amazing phantom tumor. It looks just like a mass, but it's not a tumor at all. It's just fluid trapped in the lung fissure. And the coolest part? It vanishes with diuretics. Seeing these signs just helps lock in your diagnosis.
So, we've put the whole puzzle together, right? We looked at the story, the physical signs, the formal criteria, and the visual evidence. Let's wrap all this up with one final takeaway, one absolutely crucial clinical pearl that you need to remember. So here it is. This is the one thing I want you to walk away with. In an adult patient who presents with pleural effusion, fluid around the lungs, your number one, first suspect should always be heart failure. That simple rule of thumb will almost always point you in the right direction right from the start.